Hello, everyone. I'm Mark Plaster, and this is EP Talk, the place where emergency physicians can talk about just about anything. And my guest, I guess, more like my co-host today, is JD Landon from the Tidewater area of Virginia Beach. He's with the EPT, the Emergency Physicians of Tidewater Group, and he's also one of our newer editorial board members. And I'm really thankful, JD. Thanks for joining us today.
Absolutely. Stoked to be here.
Hey, great. But before we jump into this, I want to make a note of this to all of you. The editorial board are not as old as me, but they largely are older physicians, and we're always looking for guys who are just further down the into their programs. We would consider some residents, but certainly people who are early in their careers. So JD answered that call, and we'd like to also increase the number of people involved in the editorial board. So if you have an interest in reaching thousands of people in emergency physicians world, get in touch with us, because we would enjoy hearing what you have to say. So today we JD and I have been talking a lot about ultrasound. Obviously, he finished an ultrasound fellowship last year, and
Yeah, about 2 years now.
yeah, 2 years. And so we talk a lot about the uses of ultrasound. And one of them was a paper he sent to me and that I wanted to talk to him about, was resuscitative transesophageal echocardiography in the emergency department. And this is TEE in the emergency department, as distinguished from transthoracic, which I'm familiar with, but I've never done transesophageal probes put down the esophagus, especially during cardiac arrest. You can stop CPR for, you were mentioning 8 to 10 seconds when you're doing transthoracic. Was that the number you came up with?
Yeah, I mean, so some of the early studies looking at echo or using the ultrasound in cardiac arrest, some of the early sort of question marks where some of the studies were showing that we were delaying pulse checks, right?
Yeah.
Which you can totally believe is, you do your
Yeah.
pulse check and we get in there trying to look for our reversible causes, dissection, big
Yeah.
dilated RV, clot in transit. And all of a sudden you're at 12, 13, 14, 15 seconds. And,
Yeah.
they don't want to push the doctor out of the way. And so there's a serious risk of potentially doing harm to a patient in cardiac arrest resuscitation if you're not really careful with those pulse checks.
Yeah. So that's the reason why TEE, transesophageal echo, is so important, or potentially important, because it allows you to look at what's going on in the heart even while you're doing CPR, and actually see what the effects of your interventions. If for instance, one of the things that I was looking at in here were patients who came in either weak or no pulses because of hypovolemia. When they looked at the heart, they found that in fact it was hyperdynamic. It was racing, but they were hypovolemic, and the answer to that, of course, was not CPR but fluids, and when they or blood, and then pulses came back. So it's and you wouldn't have seen that unless you heard something or saw something with the esophageal echo. So anyway, tell me a bit about this study, because it was interesting, but it's only 25 patients. It was over what did I tell you? 4 years. Who are the people that did this?
Yeah, so these are it's a cool study. Came out in the Scandinavian Journal of Trauma, Resuscitation, Emergency Medicine. It's out of Toronto, Canada. I can totally see guys doing this study over 4 years. The reason it really took so long to get that 25 patients is it was basically one guy probably was the only one in the ER who was credentialed to do TE and resuscitation and cardiac arrest. That's, for my shops and a lot of people I talk to, a lot of times that's the initial hurdle is getting your hospital system to credential you. And then, of course, the cost of the equipment. And so it was a convenience sample, 25 patients. And so it was this ultrasound director who was likely credentialed. It looks like Fraser Kegel and Jordan Chinkin, with their ultrasound fellows and their emergency medicine residents, kind of all took part in this case series.
And the patients they had, looks like they had the most common indications, obviously, was cardiac arrest, 64%, undifferentiated shock, 28%, resuscitative management. It said resuscitative management changed 76% of the time, and the working diagnosis changed 76% of the time. And 10 patients died, 15 were admitted to the hospital, and 8 survived to hospital discharge, which, after all, that's what we're doing this for. And
Absolutely. And I would note there is an interesting study, and the way it was unique. There's several other sort of prospective observational case series like this out there. Notable ones are by Felipe Tehran, who's doing some incredible work at Cornell. Arndt Feld, I think, did some really great. I think he had a 54 patient series. The thing that was unique about these guys is they actually followed up on the patients throughout their stay to look at kind of what happened, what was the final diagnosis, which is interesting. The other interesting about is they actually enrolled, like we said, a convenience sample, but they looked at patients who were just in shock, or maybe what we might call maybe peri-arrest, not just full out of hospital cardiac arrest. And obviously much of, when we look through here, much of the survival or the survivors were mostly in that shock group, which is what you would expect. But what's really interesting here is kind of asking ourselves the question, right? I mean, ACEP put out guidelines for TEE and cardiac arrest all the way back in 2017. So it's not a new idea. ACEP's already come around behind it. But the real questions are, what are we really doing here? Why should we even be doing it? Yeah. We've got a lot of physicians who are still even uncomfortable with transthoracic echo, right? So telling them, take this fancy probe and shove it down their esophagus and turn it around on this crazy omniplane, super overwhelming. But I think my argument, and one of the things that I think they prove in this paper, is that you really can do it. I mean, they were having, residents, putting the probe in
I saw that. Yeah, I saw that. It said it was performed by the staff physicians, senior emergency medicine residents, which would be pretty exciting if you're a resident to get a chance to learn to do that. But in actual fact, it's not difficult to do. There are potential complications. If you got RAMI, literally, if you got RAMI, you could damage the esophagus. You could do a variety of things like that. They didn't. I mean, they mentioned these are all possibilities, but they actually didn't have any of those bad side effects. One of the things I want to ask you about was when I was reading this, it had to do with the views. Okay. They said that the views that they used were a mid-esophageal 4-chamber view, mid-esophageal long axis, transgastric short axis, and mid-esophageal bicaval, mid-esophageal descending aorta, mid-esophageal. Just explain some of these. What are we looking at, and when would you? And they said the mid-esophageal 4-chamber was the one that they went to the most. That was the money shot. Okay.
Yeah, Mark, we'll have to regroup on this and do this with some pictures to kind of walk through this. It's ultrasound is one of those terrible things to talk about, much prettier to look at. Yeah. But a lot of these views, so in formal, full, complete TEE studies, there's around 20 views. I mean, you can really, really look at the heart in some really cool ways and angles. We've really tried to simplify the resuscitative approach to TEE. You can look out there. I believe ACEP guidelines actually is just really recommending the initial 3. Because at the end of the day, when we're doing a resuscitative TEE and cardiac arrest, we're really just looking for some very specific, simple questions. Yeah. And so, nobody's doing any fancy measurements or dynamic things like that. We're just really kind of looking at what is going on, what are some reversible causes that we could maybe intervene on. Yeah. And so, the mid-esophageal, right? So the reason that the terminology changes is that it's really where the ultrasound probe now is when it's looking at the heart. So like you said, we're inserting it into the esophagus and we're looking from the back of the chest forward. One of the reasons that this works so well is that usually there's not a lot of air back there. There certainly shouldn't be a lot of air back there. And air is one of the things we hate in ultrasound because air limits are the ultrasound waves from going there and echoing back. So it gives us these beautiful cardiac windows. And then the other little nuance that makes it really interesting is the way this probe works is it's actually what they call an omniplane. And there's a little button on the probe that you can push and literally like just rotate and change the vector in which you're looking. And if you imagine the slices that you take through the heart, and you can just change it by pushing a button. So you get multiple views without actually moving the probe up or down, just by adjusting the plane.
Cool.
So,
As if you had the probe in there and you're rotating.
absolutely.
That's cool.
It's very cool. It's very exciting. The first time, I've primarily used simulators. We're still working on our credentialing at my shops, and when you first kind of do some of these training simulators, you're like, what? This is like cheating. It's a video game. But yeah, so your mid-esophageal view when you first come down, it's really a 4-chamber view. And if you can imagine what an apical 4-chamber view would look like on a transthoracic echo from the outside, we're taking the same thing and we're literally just inverting the heart on its side. And so where we typically would be looking at the apex going up, now we're looking at the base of the heart where the atria are down to the ventricles.
Okay.
And from that initial view, there's so much information that can be gleaned. From that initial view, you can see if this is during a pulse check, is there VFib, right? Is there fine VFib? And there have been multiple cases reported where we look at the monitor and we say, oh, we're in asystole, there's nothing going on in the heart. And then you have this picture and the heart's doing this. It's just quivering.
Yeah.
Right. It's a shockable rhythm, right? One of the most important prognosticators of survival in cardiac arrest. And those might be patients where we'd say systole, you might even terminate resuscitative efforts early, thinking that the heart's not moving.
Yeah.
That's one of the really exciting ones when you can there and then turn around and defibrillate.
Yeah, I was just going to say, though, one of the things that I don't know whether they were doing it with, I didn't catch whether they did it with in their shop, but you actually can defibrillate through the ultrasound.
Yeah, I do not have any personal experience with that. I read that as well. Apparently, they've done some studies in some animals looking at actually delivering shock through the ultrasound in the setting of, let's say, somebody who has extra adipose tissue,
Right.
limiting the ability of the electricity to get through that vector and through the tissue. I mean, you can't get any better, really, other, I guess, than an EP ablation, than having it right there next to the heart. So, I mean, that's exciting.
Yeah. I mean, the very first time I did a open chest resuscitation, and they handed me the paddles, and I put the paddles on the heart. I was just shocked. I was surprised at how little electricity there is. Just this little click,
Just a couple joules.
Yeah, a couple of joules. It's just not very much. And so I thought, well, yeah, sure. Shock them, from 6 inches or 2 inches away rather than, through 10 inches of fat, so it's got to be better. So anyway, I was on another issue. So you're looking at it and you can see all 4 chambers and you can see ventricular fibrillation, which you might not see on the EKG. You can see what do you see in a PE? RV string?
That's a great question. Diagnosing PE confidently in cardiac arrest can be a challenge. The reason being, well, there's several potential reasons. The RV oftentimes is going to dilate out of the reality of poor perfusion, right? So the heart's not beating, you've got minimal forward flow, and so you can get a buildup of pressure, and so inevitably the CVP or central venous pressure is going to go up, and inevitably the RA and RV might look a little larger. Additionally, right, I mean, a lot of times, right, we walk into these patients, they're completely undifferentiated. We don't know if they have COPD. We don't know if they're pulmonary hypertensives. So just seeing a dilated RV alone does not equal PE. However, if you see somebody that's dilated RV, really hyperdynamic LV, right? So the LV is just slamming, maybe it's underfilled is another word we might use.
Yeah.
And the RV just really looks like it's struggling. And then let's say you have your friend with your good old handy transthoracic ultrasound, or you just regular ultrasound. Let's say you have them look in the femorals and you find this big clot in the femoral vein. Well, then now your pretest probability has shot through the roof, and you're feeling pretty confident about pushing TPA. Additionally, I've at least 3 cases now where I've been able to actually see clot in transit in the RV or the RA or the pulmonary arteries. And then, I mean, that's really beautiful pictures for TikTok, seeing this little booger slamming around in there. But right, you've got your diagnosis at that point, and you can move along. And the real reason, because I could totally understand people might say, well, why don't you just use your regular ultrasound views to diagnose these things? Like, and that's a reasonable statement. In this study, they were only able to get adequate views during the pulse checks in about 16% of patients.
Yep.
And I completely know why. I had a cardiac arrest 2 days ago, and I've got techs there, I've got respiratory therapists, everybody's there. We're all like right up on the patient. I'm trying to kind of reach over somebody to have the probe on the chest before we do our pulse check. A lot of times you get patients, right? This woman the other day, she had sternal fracture, rib fractures from prolonged CPR. So you got air all in the chest.
Jeez.
The defibrillator pads are right where you always want to put your ultrasound. This particular lady had a morphine pump right where I wanted to put my ultrasound probe, So there's stuff there that often can limit your view. And so, I mean, it's one of the beauties of TEs. You can put it in there, and then the real kind of OG move is to put it right where you want it, hang it on an IV pole, and then go about your business. And continue to resuscitate the patients, put in crash lines, talk to the family, and you do a pulse check. You look over your shoulder at the beautiful 4-chamber view you have, and you do your pulse check for 2 seconds now instead of 12 seconds, and say, "Oh, all right, keep going.
This is what's going on." Or now you can say they're fibrillating and you're shocking them, and you're calling it based on what you're seeing rather than the EKG or something like that. By the way, you're talking about seeing clots roll around. I was just talking to on another podcast, talking to the guys who make the machines that suck out the clots, and they get so psyched about these clots that they call it clot porn. Because they've got all these pictures of these giant clots, and they said that one of the things that they discovered was the clots were always several times bigger than what you saw on X-ray. And because we only see one side of it because of the contrast media, and so it started sucking it out, it'd be 4 or 5 times, 10 times as big as you thought it would stretch out all over the clot table. And these guys are getting all pumped up, calling it clot porn. So you're okay to be looking in there, because that's exactly what they were seeing too.
And that's exciting stuff too, because you look at when those guys are doing that stuff, you look at their PA pressures, their pulmonary artery pressures, and you look at it before and after they pull the clot, and it's just like, it's incredible. I mean, their pressures drop 30 millimeters of mercury in minutes. Now,
this particular study, I'm going to bear off of this for just a second, but we're going to jump in and whatever time we have left remaining here, we're going to go into some actual cases, and we'll talk about them individually. But this wasn't part of this particular study, but you and I have talked about the fact that TE during resuscitation can actually help you, show you where your hand placement or your compression placement. You were saying that it's you run into a situation where the RV is dilated because you have very, very poor flow, but TEE monitoring can show you exactly where to have your compressions.
Yeah, this was a new revelation for me. So there's a study, I believe it was 2009 by Huang et al. And they used TE at that time, and they went in and they saw that probably somewhere in the range of 40 to 60% of the time when we were doing CPR, we were actually pushing on the aortic root, or what we call the left ventricular outflow tract, right? Yeah. So this space in the heart where you're trying to get the blood to go through or into, let's say. Whereas you would imagine that where you really want to be squeezed in, like you might do in an open chest, is that beautiful, right? Starting at the apex and going towards the base to really get that good flow. And so, they were actually seeing that we were actually limiting potential flow out of the LV with chest compressions
Yeah.
in on nearly half of the patients.
Wow. Wow.
And so when I learned that, it was like, what are we doing? You know, it's like literally, what are we doing? And it's particularly is important because we do know that high quality CPR is one of the few things that does have a mortality benefit in out of hospital cardiac arrest. And so in my mind, you know, we don't have the studies yet to prove mortality benefit utilizing TEE to guide resuscitation, but I'll tell you what, it's coming.
Yeah.
Felipe Teran, like I was mentioning earlier, is doing some work. I just saw he posted on Twitter or X or whatever. He's just got a K-23 grant to do a large study looking at T and resuscitation and cardiac arrest, and I think they're going to do great work. And I'll be very surprised if we don't see a mortality improvement, because if you can know, you know, moving your hand 2 inches to the side, a little more inferior to really get right on top of the apex of the heart, I mean, that can change everything.
Yeah. Yeah. You get it. Yeah. Your effectiveness of CPR, that was always something that bothered me, is you'd see these studies where these guys had outrageous good outcomes. And you'd see people who you thought were doing the same thing and they were not having good outcomes.
Mm-hmm.
And you say, what are they doing different? And nobody knew that maybe they just got a better training on exactly where to put their hands. And maybe they're not moving them that far, you know?
Yeah, there's several CT studies, actually, radiologic studies looking at post arrest patients who either survived or didn't survive, and looking at, you know, where does ACLS, where's the AHA tell us to put our hands, and then kind of retrospectively saying, well, if you put your hands right here, you know, between the nipples over the xiphoid, what would the effect be? Where would you actually hit on the heart?
Mm-hmm.
You know, and it's crazy, you know, 40, 50, 60% of the time you weren't actually pushing where you thought you were pushing. Anybody who does any significant amount of ultrasound knows every COPDers patient, you know, their heart is like down in their gut almost.
Yeah.
And so the hyperinflation of the lungs pushes the heart down so far. If you were to push in a normal area, I mean, you're probably pushing on their aortic root.
Yeah.
Is where you're actually pushing.
You're limiting outflow. I want to jump in, and I'm not sure how much time we've got left here, but I want to jump in and kind of run through some of these cases. They list them all because when you have only 25 cases, and you can kind of say what they did. A 66-year-old female who had global hypokinesis. I've got what it is the presentation was shock. Okay. Global hypokinesis, cardiogenic shock was the post-resuscitative diagnosis. And by giving her inotropes, she survived.
Yeah, I got to tell you a good story about that, Mark. One of my early clean kills, as we say, you know, most of the patients, right, they come in hypotensive, tachycardic, diaphoretic, right? The majority of these patients are all going to be sepsis, right? I mean, the vast majority of the hypotensive, shocky patients we're seeing are sepsis. And what does the government command us to do in sepsis, right, is to give this unproven 30 cc's per kg fluid bolus. Well, I don't know about where you practice, but where I practice, some of these people are packing quite a few kgs, as it were. And you know, if you actually follow that, you're talking about giving somebody 3 liters, 3.5 liters as a bolus. And you know, if they're sepsis and haven't had anything to drink or eat in 3 days and pooping out of their brain, you know, at their brains, then it's probably fine.
Yeah.
However, when the patient comes in tachycardic, hypotensive, and it's because of a massive PE, and you start blasting them with fluids, that's what we call a clean kill.
Yeah, you'll kill them.
And I'll tell you what, man, I was up for days thinking about that case, and I read everything I could on the topic. And never again have I ever given a single liter of fluid without first ultrasounding the patient or seeing prior records about their, you know, whatever's going on. And this is one of those things where if you can get the data, you know, mid resuscitation, you can really potentially save lives.
Yeah. Completely reverse course here. This was a 56-year-old male, hyperdynamic LV, and was once they got the TE, found hypovolemic shock, They gave him fluids. Guy survived.
I mean, if you know what you're dealing with, the game
Yeah.
gets a little easier.
Yeah. Here's a 47-year-old male cardiac arrest, PEA asystole, and 47-year-old, that's probably what got everybody motivated. If it'd been 87-year-old with PEE asystole, you wouldn't have done anything. But this was when they put the TEE in there, we found his whole right ventricle was full of clot. He's not going anywhere.
Yeah, and I forget whether it was this study or another study where they were looking at, I think it was one of Felipe Teran's study where they actually measured how long is it taking them. If somebody comes in, they're crashing, you got all this stuff to do just to kind of get the resuscitation into a groove, right?
Mhm.
But they showed that, I mean, they were getting the TEE probe in the right position and getting views within 5 to 8 minutes.
Wow.
And as I've learned and gained more experience in my own career, I've realized that the faster that we can get to determining a reversible cause, I mean,
Sure.
time is perfusion, right? And so
Sure.
so being able to get the views, get the information, and then make the decisions fast. In this situation, minutes do matter.
Yeah. Here's a 66-year-old male cardiac arrest, VF, and TE saw regional wall motion abnormalities, and immediately knew that it was an MI, and went to cath lab. Um,
That's probably one of my favorites. I've had this happen to me one time, and it really requires you to have a little bit of a relationship with your cardiologist. Because I don't know about where you work, but a lot of times the cardiologists are not always impressed when we say, yeah, I get that it's not official STEMI criteria, but I just really feel like this
yeah,
patient's occluding right now. This is an OMI, right, or an OMI.
yeah,
A lot of cardiologists are not impressed or interested in getting up out of bed, which I understand they're busy. But when you're able to say, hey, on the anterior lateral wall, it's hypokinetic, or there's dyskinesis here, and here I'm going to take a picture, I'm going to send it to your cell phone right now. One time I've had a cardiologist get right out of bed and come in, and I mean, they probably save that patient's life.
yeah,
um,
yeah.
Being able to get to the diagnosis.
Here's one that it is sad, but certainly it helps us. 66-year-old male cardiac arrest, PEA asystole. When they looked in the TEE showed cardiac standstill. It's just nothing, not there.
Yeah.
Yeah,
Yeah.
yeah.
And I appreciate this. I do this with every single cardiac arrest that I terminate efforts on. And for multiple reasons. A, there's really good evidence that cardiac standstill really does portend nearly 0% neurologic survival. It also allows the team, right, who is putting in effort, I'm sure having various levels of emotion about the resuscitation, allows them to all kind of know, we didn't kind of leave anything on the field, as it were.
Right, right. And the family. Yeah, in the family, you can actually say, we
Yeah,
looked,
absolutely.
the heart was not beating, and we when we stopped. That's really helpful. Here's an interesting one. Cardiac arrest, PEA. Okay. TE shows right heart strain, pulmonary embolism. Okay. Anticoagulation, and patient survived. There you go. Came in cardiac arrest, PEA. I mean, the number of those that I have actually seen survive, I can probably count on one hand.
Yeah.
Yeah.
And you're so right, particularly with our mentality about cardiac arrest in general, right? I mean, I think anybody says PE, I think we all probably subconsciously or consciously are thinking, okay, where's the family, right? First question, where's the family?
Get the room ready. Yeah. No.
And if you have tools at your hands that you can use to potentially, look for some reversible causes, I think it definitely gives you a little more hope.
Yeah. Well, anyway, I think that this was really fascinating for me to see. Obviously, a lot of these cases we're going to expire, and in fact, 16 did. I think. You recall the numbers? I think 16 expired of the 25. 64.
Yeah. and like we had said, the majority of the survivors in this group, to be clear about this, were people who came in diagnosed with shock, right? Not cardiac arrest. I think there were only a handful in here who came in cardiac arrest. We don't know how long they had been down. We don't have a lot of those granular details, but really, I think a lot of these early studies for TE are really looking at how is it changing our management? Because that's always a reasonable question whenever we're introducing a new tool or a gadget or something that's going to be costly to the system. Like, does it really affect your management, right? We've been through this with, Swan-Ganz catheters in the ICU, all these different, interventions. We have to kind of back up and say, is this actually changing our clinical management?
Yeah.
And the other thing I would note that this does require effort to learn, some effort. There are some interesting studies that have showed that, a course, a 4 to 6 hour course on resuscitative TE for emergency medicine, and then some hands-on practice in the OR, whatever, is what it takes. Now, when you step back, like, well, okay, that's like 2 days. That's really not a whole lot of knowledge that's required. But it does take an institution that's willing to support you, get the supplies, figure out sanitation. If you're going to do, a reusable probe, the probes are not cheap. Cost for a lot of institutions, I'm sure, will be a factor. But I mean, we're in emergency medicine and this is resuscitation. So it's.
Yeah. I mean, resuscitation, if we can just remember that resuscitation was almost the reason for our specialty, 40, 50 years ago when I started, and so if we can actually improve that core skill and we can show that our CPR is actually working, and by actually looking inside, not being stuck with palpating pulses with our little fat fingers, and that sort of thing, and be able to really know definitively what's going on, better information, maybe not definitively, but better information. I think that we definitely have a better, I hate to say product, but a better offering to our patients and their families. So, JD, thanks. This is always, as usual, it's always very instructive. You bring a lot to the table, so thank you so much. And I say again to our EPs that are early in their careers, you're doing things that old dogs like me didn't do and didn't learn how to do, and it's important that you share your knowledge and your questions and your discoveries and everything else with the larger world of emergency physicians. And no better place to do that than EP Talk. So if you'd like to join us, drop me a line at erdocmark at gmail.com. And I'd love to hear your thoughts, your suggestions, or your nominations. So thanks for joining us. JD, thanks. We'll see you another time.
Sounds good. Take care.